All right, so it's 4:30, and good afternoon once again. Those who joined in late may have noticed that the sound was muted. We had earlier announced to participants about the fact that we'll be starting at 4:30. Apologies if you joined late and did not hear this. So today we're looking at ECGs. It's going to be an interactive session for those who are in-house. The objectives are to recognize the normal rhythm of the heart. Of course, most of us, when we hear about ECGs, we run away because it brings a lot of palpitations even to the one who is supposed to interpret. That's if you don't understand. But you realize that it's a very simple tool that, of course, if you're able to make good use of it, you can't even in the remotest of places be able to make very simple diagnosis and make life-saving diagnosis. So we're looking at being able to recognize what is normal and look at now what is abnormal, the common rhythm abnormalities, how to recognize an MI and then an AV block. So typically, you usually say that you see one, you do one, and then you teach one. That's how it stays. This is how the normal impulse from the heart goes, from the sinoatrial node, otherwise called the SA node, moves to the AV node, and then to the bundle of His, to the bundle branches, and then to the Purkinje fibers, as you can see in that diagram over there. Again, same kind of impulse conduction, and the way it's illustrated on the ECG. So the P wave, like we see in the first red, you have that as showing the atrial depolarization, and then followed by a rise before the QRS complex to the T wave. So typically the ECG, if you look at it, you have what we call the PQRST. So the P wave, like I initially said, is the atrial depolarization. You have the QRS, which is the ventricular depolarization, as you can see in there. And then you have the T wave, which is the ventricular repolarization. So it is what it is. Now let's look at the PR interval. So once you have the atrium being depolarized, that's the top part of the heart being depolarized, you need to have a rest in between that before you have the lower parts of the heart, that's the ventricles, being depolarized. So if in between or from that atrial depolarization to the ventricular, start of the ventricular depolarization, of course, you have the PR interval. This allows the time for the atria to contract before the ventricles will then contract. Now we are going to look at the pacemakers of the heart, i.e. what makes the heart rhythm go. So we have the SA node, which is usually the dominant one. But mind you, the intrinsic properties of the heart is such that all the cells of the heart actually have that kind of ability to be able to contract. So if the main man, the SA, doesn't go on to contract, some of them can take that automaticity. That's a property that we usually describe. So you have the AV node, which can usually fire between 40 to 60, and then the ventricular cells, like I've already mentioned. So let's look at the ECG paper. Typically, when it's done, what you see. So you have, it's just like what we used to use in basic school, like the graph. So you have bigger boxes and smaller boxes. The very small box is usually 0.04 seconds. That's if you are looking at the horizontal axis. So it makes sense that usually if you have 5 of those ones, that will come to 0.2 seconds. All these are important because, like we'll see when we come in to look at abnormalities and all of that, we'll see. This is what I've just explained. Now to the vertical axis, each small box over there is also 0.5 millivolts. So vertically we measure in amplitude, i.e. millivolts. So a smaller box will give you 0.5. Then horizontally we measure in time because its duration takes time for the heart to contract. So now a typical ECG paper is what you have there. Every 3 seconds, that's every 15 large boxes if you count. It's marked by a vertical line. And this will usually help us to calculate the rate. That's the next thing we're going to really look at as a beginning to how to interpret the ECG. So typically, if you count between this box there, the very small one, to so this I mean to the last one there, you realize that that's about 30 boxes, because for every 3 seconds you have 15 boxes. So in all if you have 30 even. So if we are looking at the 3 with 3 there, that will come to about 6 seconds. And we can use this in calculating the rate like I've earlier mentioned. So now, how do we do the analysis of the rhythm? First, you determine the rate. We are going to look at that. We'll look at the regularity of it. We'll assess the P waves. We'll determine the PR interval. Then we'll look at the QRS. So the rate, everyone needs to be able to calculate the rate. It's very easy to do. We are taking it step by step. So stick around and listen attentively. I'm sure you'll be able to get it because it's very easy. One way of determining the rate is that you usually count the number of R waves in the 6-second rhythm. Like I mentioned, like what you have here, this is about 6 seconds. Because if you count the boxes from here to there, that's about 30 boxes. And if you agree with me, or you had listened to me, realize I said that the tiniest of boxes is 0.04 seconds. And so a bigger box will come to 0.2 seconds. And so the whole of this from there to that would then be a 6-second rhythm. And so if you count that 6-second rhythm, typically you only need to know how many R waves are in that, and then you multiply by 10. Very simple. So if we are going to look at this one, the number of boxes that we have, the number of R waves that we have in here, what's our interpretation? So obviously those in-house with me will be answering all the questions when it gets to the question. So Dr. Jaula, you will take it. What's the interpretation if you are going to use the R waves to calculate the rate in this 6-second ECG rhythm strip? That will be 54. Okay, so if you have about let's say 6 seconds here, and then we'll calculate the number of, just calculate the number of R waves. The R wave is the positive deflection, that also. So 1, 2, 3, 4, 5, 6, 7, 8, 9. Is that not it? Am I right? So you have 9, is that not 9 waves? So of course, if you are multiplying 9 by this, what do we get? So get 90, is that not it? So that's the rate if you are using the RR. Okay, so move on. The next one, or the next option that you can do, which is usually even more common, is what we would look at the number of big boxes. That is this kind of box between one R wave and the other R wave. So if you count the number of large boxes from one R wave to the other, in between the two, and you divide 300 by that, you'll be able to get the rate. So very simple as well. So once we are done with the rate, we look at the regularity of the ECG. How regular is it? And regular just means that you look and be sure that from an R wave to the next R wave, or from a P wave to the next P wave, it's the same time. So this is a P wave to the next P wave. It's the same time that it takes, or it's the same angle if you are going to measure with the clippers, or you are even going to use a paper. So between this and this, between this and that, between that and that. So typically you have that as your regularity. If it's all the same, then obviously it is a regular rhythm. So if you look at this one that we have put up, you realize with me that the RR between here and there, between here and there, if you have an eye of faith like mine, it's all the same. So we think that this rate is regular. So the interpretation is that it is a regular rate. Sorry? So I realized people said I'm going too fast, so I will slow down. But I think maybe when we slow down, we may not be able to finish. But it's good that we're able to grasp the concept. That's the more important thing, rather than going faster. So thanks for the feedback. So this is regular. Let's go to the next one. That's assessing the P waves. So like I said, the ECG, all about the ECG is PQRS. That's all. That's all about it. So we'll take it one after the other. The P waves. How do we assess the P waves? First, we want to be sure that are there P waves. So like you can see over here, we find a P wave. That's like I initially said at the beginning of the presentation, that is where we have atrial depolarization. So you find another P wave over there. You find a P wave there, a P wave there, a P wave there, a P wave over there. So are there P waves? Obviously, the answer is yes, we have P waves there. And do the P waves all look alike? That's another thing that we have to be sure of. Once you look at the P waves, you want to be sure that they all look alike. And so if you look at these, all the P waves do look alike. And do the P waves occur at a regular rate? Already when I was talking about the RR interval, instead of using that, sometimes you can also look at the P waves. And so if you look at this graph here, you realize that the P waves do occur at a regular rate. Then is there one P wave before each QRS? Why do we say so? Because you have the top part of the heart, otherwise called the atria, or what in the past they used to say auricle. So the atrium will contract, showing the P wave. There will be a delay as by the AV node, and then you have a QRS representing the ventricular contraction. So for a normal heart, that is a sinus rhythm. The normal ECG is usually where you have a P wave preceding each QRS interval. So you want to be sure that this is the norm, and that's what the fourth option there is asking. And so if you are able to look at all this, and it does follow, then you realize that this P wave is normal. And so you say there's a presence of P waves, and these P waves are of normal morphology. We'll look at some problems with the P waves in subsequent presentation. Right, so we move on. We've been able to, just to recap, we've been able to determine how to assess the rates. Next, with the rhythm. And now we are looking at the P waves. The fourth will be from the P wave, where do we go to? The PR interval. So the PR interval, like I already said, usually that is from the atrial depolarization to the beginning of ventricular depolarization. So the normal is usually 0.122, 0.2 seconds, i.e. other people usually count in boxes. So it says from 3 to 5 boxes, the small boxes, not the big ones. And so anything bigger than this, you think that the PR interval is prolonged, and there are causes of that which we'll look at. So if we look at the ECG above there, and we want to throw the question to the floor, is this a normal PR interval? If you can see with me what it is it normal? All right, so I got the response that is here. So then it's about 0.12 seconds, and that's normal because we said that the normal is between 0.12 to 0.20 seconds. That's between 3 to 5 small boxes. Next, we look at the QRS interval. So the QRS duration, sorry. So the QRS duration, of course, that's the ventricular depolarization. Now, the normal duration is usually between 0.04, that is one small box, to 0.12, that is 3 small boxes. So whichever way you want to put it, either you want to measure accurately as in the seconds, or if you want to keep it easier with the small boxes and the big boxes, that would be 1 to 3 small boxes. So if you look at the QRS duration that we have put up, is this a normal QRS duration or not? I think I would invite the participants as well, those on the Zoom, so that it can be an interactive session. So let me see who is the first person up. Unfortunately, people have not joined in with their names. So, okay, Abakisi Derek, if you can unmute yourself and then contribute.
Yeah, it is normal.
Fantastic, thank you. So this is normal QRS duration. So that's 0.08. And if you look at what we have seen, it's 0.04 to 0.12 seconds. Thank you very much, Derek. So we'll move on. The next thing is to look at our rhythm. Usually the summary, like we have said. So if we determine the rate, we look at how regular it is in referring to the ECG up there. And then the next thing is the P waves. So this is everything is done in order. If you jump to crash because you miss a lot of things. So we start with the rate. We've determined that the regularity, whether the P waves are equidistant. So from one R wave to the next is the same as from this R wave to the next is the same as from this. So like I can see in this ECG or from this ECG, it is a regular R interval. And so the regularity is regular. Now we look at the P waves. The next, like we have said, the atrial depolarization. And so that is also normal because one, we said we'll be looking at whether they are present before every QRS complex and the morphology of them, which we'll be looking at shortly. Then the PR interval, that was the next thing we talked about. Then the last but not the least was the QRS duration, which we said was 1 small box to 3 small boxes, or 0.04 to 0.12 seconds. Okay, so based on what we have just talked about, you realize that the ECG is extremely simple. You are done in terms of a normal ECG. So what's the interpretation of this? You have determined that the rate is about this. It's a regular ECG, it's normal. The PR interval is normal. The QRS is normal. So this is what we call a normal sinus rhythm. Great. So a normal sinus rhythm, typically the electrical impulse is formed in the SA node, which is usually located in the atria, and then it's conducted normally. That is what we would refer to as the normal rhythm of the heart. Any other rhythm apart from what we have just learned is an abnormal rhythm, what other people call an arrhythmia, or what in the past commonly they will say dysrhythmia. So what are the parameters? If you are going to look at that, like we said, the normal rate is usually between 60 to 100. The ECG, for it to be a normal rhythm, it has to be regular. The P waves have to be there and they should be normal and preceding every QRS interval. Then you have the PR interval between 0.12 to 0.20 seconds, or you say 3 to 5 small boxes. The QRS interval between 0.04 to 0.12 seconds. Again, either if you want to go for the other aspects, from 1 to 3 small boxes. So any deviation from this is referred to as either a sinus tachycardia, a sinus bradycardia, or an arrhythmia. Now, we're going to look at how an arrhythmia is formed. They can arise from, okay, just before we go on to that, I would ask anyone who does not understand the basis to let us know so that then we can go over that before we continue. The rest is just going to look at now problems of the ECG. So this is essentially like the end of the first part. If you just wanted to learn about normal ECG, it will be better to exit now because you may just mess up the mind if you are going further on. If you want to continue to look at pathologies, then we can go through that. So let's see. I would ask people to unmute themselves and ask a question or make a contribution if you want to. Okay, so that box has been enabled. If you have a question, kindly unmute yourself, and then you can go ahead and ask the question.
Yeah, Doc, let me ask this question. After the QRS, there's another this, whether you have not explained that you ended with the QRS.
Sorry, on the Zoom, kindly just give me a minute. Let me turn the microphone to loud because those in the room do not hear you, and I don't think it's fair to them. Hello? Hello?
Yeah, hello. Can I ask mine? My name is Isaac.
Please hold on, Isaac, please hold on. Hello? Yeah, so Bismarck, I think Bismarck should ask his question now. Then afterwards you can.
All right, thank you very much. You talked about the P wave and that of the Q.
Bismarck, your line is terrible.
After the QRS, they talked about it. So if you can see. Yeah, yes, but the other wave after the QRS, you never said anything about it. If you can.
Yeah, so we'll look at that. That's the T wave.
All right.
Yeah. Any other question? Yeah, so in our someone asked a question.
Thank you. My question. Please, Doc, I was hearing depolarization of the, and you were talking about the P wave. That is where the atrial depolarization occur, but I don't know whether there is a repolarization of the atrium. Where do we locate that?
Yeah, so of course, once the atria get depolarized, the repolarization is not captured because they are of the muscle mass is less. And so once it gets in, the AV node does have a delay before it gets to the QRS, that's the ventricular contraction or ventricular depolarization. The other one that like Bismarck asked, I left out was the T wave, which is for, once it's asked, let me bring that in so that it becomes complete, which is for the ventricular deep repolarization. Just a minute, what I will do is that because in-house people do have a lot of questions as well, I would rather plead that those online, you put up your hand so that then I can unmute you and then you can ask your question so that we can allow those who are in-house as well to be able to. Otherwise, once you're asking yours, they cannot do that. So kindly bear with me. I'm muting everyone again. If you do, then you put up your hand and then I'll mute you. Okay, please go ahead with your question. The calculation of the rate. All right, so there were two. Let's go back to that. Yeah, that's it. Yeah, so what was the question? You don't know how to, all right, so two ways of doing it. One way, the common way is option 2, where you would want to look at between, let's go back. Yeah, so that's it. So you find an R wave that lands on usually the ticker line, and then you trace it to the next R wave. And then you count the number of big boxes in between one R wave and the next. You divide 300 by that. The thing is that with this particular method, you need to be sure that the rhythm or the ECG is a regular one. Those that are not regular, this first option would be a better way to calculate. The first option, that is, you count the number of R waves in the 6-second rhythm, and then you just multiply it by 10. So if you are with me, if you look from here to there, it's 6 seconds. So we just need to calculate to get the number of R waves in here. So if you count, you have 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9, you multiply 9 by 10, what do you get? You get 90, and that's the answer then. All right, great. Any other question in-house? Yeah. Yeah, so if it's a 10-second strip, you can, if you would count the number within those 10 seconds, instead of multiplying it by 10, you multiply by 6. So you are looking at what happens in 1 minute. That's essentially exactly. Alternatively, even if you have a 3-second strip, you can actually calculate it, but it's not as accurate as having either a 6-second strip or a 10-second strip. Yeah, thanks for bringing that up. In-house, any other? Yeah. No, so I said there are 2 of them. They can actually add a third one if you want to be a purist. 1,500 divided by the number of very small boxes, and you can get it. Okay. So on the Zoom, any issues before we move on? If you have any question, kindly unmute yourself and ask. Okay, then we'll move on. So now we are going to look at abnormal things. First, the arrhythmia formation. So arrhythmias can usually arise from problems in the sinus node, i.e. SA nodal problems, or the atrial cells, or the AV junction, or even the ventricular cells. So either the problems can be that one, the SA node is too slow or it is too fast. That is, it's either firing too slow, what is referred to as bradycardia, sinus brady, or it's firing too fast, a tachycardia. The thing to note is that, of course, when I'm coming to do the presentation and I have some palpitations and you do an ECG for me, my heart beats too fast. And so you find that it will be more than 100. That's not the time to probably think that is an abnormal thing. And that's the reason why ECGs, like the favorite writers of the books, will tell you that it's as not good at all as allowing the machine to do the interpretation for you. Unfortunately, most of us, that's what we do. We look at what is written up there without any clinical picture, without any this, and I even actually see that people sign on top of that as the official report. It's not the best. Really, if you know how to read, you realize that the ECG machine sometimes leaves out a lot of things. Sometimes we diagnose what is not there, and sometimes bring in stuff like unspecified T-wave abnormalities. So if you realize that, what does that mean? But if you follow through and you're able to do it yourself, you realize that it's quite an easy thing to do. So like we said, if it fires too slow, it's a sinus brady. Fires too fast, it's a sinus tachycardia. So the atrial cells can also usually fire continuously from multiple foci. That's what we call the atrial fibrillation. Or they can fire continuously due to multiple reentrant wavelets. That's again for the atrial fibrillation. That's it for the atrial cells. How about the ventricular cell problems? The ventricular cells can also occasionally fire from one foci. That's what we call the premature ventricular contractions. Or they can fire continuously from multiple foci, which is even dangerous, the ventricular fibrillation. Or they would fire continuously due to looping of reentrant circuit. That's the tachycardia. Now, the arrhythmias that can be sinus problems. They can be premature beats. You can have, like we just said, premature ventricular contraction, premature atrial contractions. You can have what we call the supraventricular arrhythmias. You can have the ventricular arrhythmias. You have AV junctional blocks. So if you are looking at the sinus rhythms, you can have the sinus brady and tachy. I think we've already talked about this. So let's look at this one. Those in-house, those who all ask me questions, I also throw questions to you. So the rhythm, I think we have talked about this when we were doing normal ECGs. So what is the rate here? Once you ask me a question about the rate, I'll throw it to you. So count it for me. You've already said. So just the rate using the second option. What do you think the rate is? Because this is not up to a 6 second strip, is that also? So if you count the number of boxes between this R wave and the next one, how many do we have? And if you divide 300 by that, what do you get? Any answers?
Oh.
Sorry? About? Okay, so what do we get? Okay, so about 38, is that not so? So here we have 30. Of course, less than 60 is bradycardia, is that not so? The regularity. Do we have a regular RR interval or it is different? Any answers? Is it regular or irregular? Is it regular? If you count the number of boxes from here, if you're using, what do you call it? Either a sheet or a clipper, you mark, or caliper or something that is from here to there and compared from here to there. I thought it's the same. Is that also? All right. So it's regular. Then the P waves. What do we think? Are there P waves at all? So we have P waves there, a P wave there, a P wave there, a P wave there. Are they normal looking? We think it's normal. Now we look at the PR interval. If we look from there to there, or from here to there? Do we think it is normal? So it's about 0.12 seconds. And like we said, the normal is between 3 to 5 boxes, or 0.12 to 0.20 seconds. Is that also? QRS duration. Do we think this is a narrow complex QRS? Do we think this is less than 0.12? I think so. So it's normal. So 0.1 seconds. So realize that in terms of rhythm, just recapping what we have done, this should be a normal rhythm, sinus rhythm. Okay, great. So what's the interpretation? I think I've already given that out. Sinus bradycardia, because of the low, slow heart rate. Okay. We look at the next rhythm. What's the rate here? Those on the Zoom, I think you will do the second one. Anyone could just unmute and answer. What's the rate, please? Dr. Amina, I see you are talking.
Yes, sir.
Yes, go on, Thomas.
Doc, about
Yes, so I think this is about 120 beats per minute.
Okay, so you think it's a fast rate, is that also?
Yeah. Yes,
It's more than
please.
100. Okay,
Yeah.
great. Okay, so Thomas says it's about 120 beats per minute. Okay, let's move. So 120, 130, I agree with you. Good. Regularity, anyone? Is it regular or irregular? Fast, so that we'll move on.
It's
If
regular.
anyone could unmute them. Yes, please go ahead.
It's regular.
It's regular, fantastic.
It's regular.
All right, the P waves, are there P waves at all? Do we have
yes,
P waves?
Yeah.
they are.
Yes,
Yes,
there
we
is.
have.
Are they normal?
Yeah, normal.
Yes.
Yes,
Great.
please.
So we have a normal P wave. Let's go to the next one, PR interval. What's the PR interval? Normal, abnormal?
Normal.
Okay, normal. What's the normal, please? What's the normal PR interval, since we have talked about this?
3 to 5
0.1.
0.2 to
0.12.
0.20.
Yeah, great. So three. I mean, I like things the easier way. 3 small
3 to
boxes.
5 boxes.
To 5 boxes. That also. So 0.12 to 0.20. Okay. So this is 0.16. So obviously normal, falls within that range. The QRS duration, we said that's 1 to 3 small boxes, or 0.04 to 0.1.
0.12.
Okay, so this QRS duration here, is it normal or abnormal?
It's normal.
All right, I agree with you. It's normal. So what's your interpretation of this ECG?
Sinus
sinus
tachycardia.
tachycardia.
Fantastic. So sinus
It's
tachycardia.
abnormal.
Is it that the thing is easy to do? Then also, let's go to the next one. So this is a sinus tachycardia. And of course, the rate is more than 100. We said normal rate is 60 to 100. Great. So with sinus tachycardia, you have the SA node being depolarized faster than normal. And so it will fire faster. And maybe a response to a physiological stress. Like I said, maybe you have a presentation that your heart is jumping about it and all of that. So it may not necessarily be a pathological thing, but it may be pathological as well. Like those with pulmonary embolism, those with thyrotoxicosis and many other conditions could come in sinus tachycardia. All right. Now it gets more complicated, isn't it? We go to the supraventricular arrhythmias. So supraventricular obviously just means that above the ventricles. English, is that also? So those ones, you have atrial fibrillation, atrial flutter, then they have the paroxysmal supraventricular tachycardia. I think these are the common diseases. There are even some that have been left out of this. So of course, those who want to hit in on those ones can go. The MAT and the PAT. So the multifocal atrial tachycardias and then the paroxysmal atrial tachycardia, all those ones are there. So you can probably look that up. But for the layman like me, I'm fine with atrial fibrillation, atrial flutter, paroxysmal supraventricular tachycardia. We'll go. So let's look at this rhythm number 5. What is the rate? Zoom people.
100 beats per minute.
You think the rate is 100 beats per minute? How did you get the 100 beats per minute? Yeah, anyone can answer. Like how you got the 100 beats per minute.
You counted
Yeah.
Yeah, please, it's not
Array.
regular.
the R wave. R wave.
Okay,
300
It's not regular.
divided by
great.
10 divided by
I
100. Our peaks times 100.
I get the point. So the thing to always look out for, like I initially mentioned, is that if you are going to use that 300 rule, if you divide 300 by, there are 1, 2, 3, grossly 3. So 300 divided by 3 will give you 100. Is that also like some people had mentioned? But let's assume you selected that and I selected this one. So I would have divided 300 by 1, 2, and that will give me 150. Which of us is right and who is wrong? Or even another person decided his village is far away, so he decided to go in to use this. So if you are going to use this, the boxes, so that would have been 1, 2, 3, 4. He decides to divide 300 by 4, and it gave him 75. Which of us is right? So the thing is that always be on the lookout. If it is an irregular RR interval, you cannot use the 300 rule. So the second option will be your best bet. So using the second option, yes, sir. Somebody is.
Yeah, I counted the number of R waves. There were 10, and then I multiplied it by 10.
Fantastic. So you got 100 by counting the number of R decimal. That's great. So that's actually what we may have to do, because if it is irregular, we cannot agree with the one who counted 75. We cannot agree with the one who said 150. Neither will you agree with me who said 100, because of course, this is not the same as that or that way. So the reason for this is that it should point out to us that if the rate is irregular, you need to use the 6-second or the 10-second rule and appropriately multiply by whatever you get. So the 100 beats per minute is very right. Regularity, I think we have already answered this, so we'll move on. It's regular.
Yeah,
It's irregularly irregular, sorry. Then the P waves. Okay, we haven't answered this. So what are the P waves here, and are they normal? Anyone on the Zoom, kindly take us through.
Yeah, I have seen about 2 P waves, but they are not normal.
Okay, so you think they are P waves?
Yes.
You think that they are P waves, but they are not normal?
Yes, please.
Okay, fantastic. And you see 2 of them.
Yeah.
In the whole of this ECG, you saw two P waves. Is that also?
No.
There are 4.
There are 4.
Plenty.
Okay.
Yes,
There are
please. There are
plenty.
4 that I have seen.
Okay, great. So there's actually, I cannot see that much. So these are what we call undescendable P waves. You can't really see the thing. Like somebody said there are 2. Another person said there are 4. Another said there are plenty. So we'll argue from today to tomorrow. Somebody will even say there are 1 million. So because of the fact that they are not too clear, it's better that we say we cannot see them well. And if we can't see them well, we say the P waves are not there. They are undescendable. Now, the PR interval. Is there any PR interval that we are seeing here? Anyone on the Zoom?
No.
Okay, so I agree with you. You can't see any.
Arba no P.
Fantastic. QRS duration. What's the duration, please? Anyone at all? QRS duration. Zoom people.
It's normal.
It's about 0.08.
All right, so it's normal. Is that also? So it's about 0.08, 0.06. That's all fine. And that falls within the 1 to 3 small boxes, or within the 0.04 to 0.12 seconds for those who want to be purists. All right. So based on all that we have talked about, so you have had the rate that is 100, there is irregularly irregular. The P waves, you cannot see them well. The PR interval, you can't see anything because you can't even see a P wave. The QRS duration is a narrow complex, 0.04. What's the interpretation? Zoom people.
Atrial fibrillation.
Anyone? Or what's the diagnosis?
Atrial fibrillation.
Atrial fibrillation.
Fantastic. So this is an atrial fibrillation. Great. So move on. So what is an atrial fibrillation? It's just a deviation from, of course, the normal sinus rhythm. So in that, we don't have any organized atrial depolarization, i.e. the P waves. We said that P waves represent atrial depolarization. So you will not have normal P waves. And the atrial activity is usually chaotic. So you have an irregular rate. And typically by way of, what do you call it, prevalence, it affects about 2 to 4% of people. And sometimes as you grow old, you are more at risk of atrial fibrillation because, of course, there are a lot of issues that a lot of people do have, like underlying heart, structural heart issues, and then fibrosis and all of that. Okay, so let's have a try at this one. Already, I think I've given the answer for the first part away. The rate is 70. Okay, so this one is to those in-house. Rhythm number 6. Is this regular or irregular? Oh, those in-house. Anybody at all can answer, so that we'll move on. Is that also? It's regular. All right, I agree with you. P waves. Are there P waves or there are no P waves?
It's all like
No P waves.
No P waves.
Fantastic. You actually call them a particular kind of flatter waves. They look like sawtooth. Saw. Those who have felt the saw that they used to cut wood before, you realize that the teeth look like that. These ones. Okay, so let's move on. What's the PR interval? Is there a PR interval, and what is it? In-house. There's a PR interval. Okay, so we don't see any because of the fact that you have between here and here, there's no R wave. So some waves do not have R wave. So it's difficult to say a PR. So this would be like a PP. And because of that, you cannot calculate the PR interval. That's the reason. Those that have, obviously you have that one here, but cannot represent all of the ECGs. How about the QRS? Do you have a QRS there? So we have QRS. Is it normal or abnormal? It's normal. Fantastic. So it's about 0.06. So what's the interpretation? Atrial flutter. Fantastic. Okay, so move on. So atrial flutter, typically you don't see the P waves. Instead, you have what they call the flutter waves. These. Then, of course, we talked about the sawtooth. Only some impulses will go through the AV node, and usually some of them do not. So you realize that there's atrial contraction there, that you don't have a QRS, i.e. ventricular depolarization. Okay, there's someone who is talking in the background. Kindly mute yourself. Rhythm, yeah, Santi, please mute yourself. Or if you want, you can answer this one. So the rhythm number 7. Zoom people. What's the rate?
110. 110. Yeah.
Okay. So depending on how you see it, it can be within that. What's the regularity? Is it regular, irregular, or any of those things?
It's irregular. Irregular.
It's irregular.
Yeah.
Okay. All right. So let's go. Then how about the P waves?
There is P wave.
The P waves.
Yeah, there's P wave.
Okay. There's P wave.
All right. Okay, fantastic. Then how about the PR? The PR interval. Do we have any?
No.
QRS duration.
It's normal. Yes, enough.
Who is this? Yeah, please mute yourself. So our interpretation is a paroxysmal supraventricular tachycardia, because, like we said, some of the
sir, please unmute everyone. So that, sir, mute everyone.
Yeah, when is that way? You can be interactive. Is that not so?
We can unmute ourselves. So everyone, then we unmute ourselves when we want to talk.
Yeah. Okay. Great. So
Madam, he said there also kasa ever peke. And I feel no kasa kasa biaba and
all right, so everyone is muted. I beg you don't unmute yourself if you don't want to answer a question. So I was saying that you move from a rate of 74 to about 148 beats per minute. The initial part, the rate was regular, and then the other one, the rate is still regular. Then if, like you notice, from here, you did have P wave. This is a 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 P wave. But after here, you don't, this is a T wave. It's not a P wave. So there's no P wave here. This is a T wave. There's no P wave. So you realize that there's a presence of P waves goes through, and there's no, the second portion of it, you don't have P waves. You see, the way the ECG is, if you rush to crash. So you have to take your time to look at how the things are. Now about the PR interval. Anytime there's no P wave, there's no way you can calculate a PR interval. Is that also? So in the first part, you'll find that this is a P wave, so there's a PR interval. But over here, there's no P wave. So how do you get the PR interval? So that's why the second portion says none. Then the QRS duration, of course, every part you find a QRS, and it's about 0.04. And that's the reason why we say this part was okay, was normal, and has become a tachycardia, an abnormal descent. And so this normal part plus the abnormal part is what we are calling the paroxysmal supraventricular tachycardia. Okay, we'll move on. So we are done with the top part, the supraventricular tachycardia, or supraventricular arrhythmias. We'll go to the ventricular guys. So you have ventricular tachycardia and ventricular fibrillation as a common distance. Issue is that these things, you really, those who have done BLS, ACLS, you realize that these are rhythms that you should know very well, because if you don't know, then there's no way you get the American Heart Association to certify you. And also, rhythm number 8. What is the rate? If you are ready, please unmute yourself and let's know what this rate is. Otherwise, in-house, anyone who knows the rate.
160.
Sorry? 160. Okay, someone gives the answer as 160. Fair. Fantastic. Is it regular or irregular? It's regular. All right.
It's regular.
Are there P waves? There are no P waves.
No P waves.
Is there a PR interval?
No.
There's none. What's the QRS duration? Normal or abnormal?
Abnormal.
All right. So this is wide QRS complex, and that's even the reason why it's a ventricular issue. So what's our interpretation? Fantastic. So this is a VTAC. Let's move on. So VTACs, usually the impulse is originating in the ventricles. We said that the way the heart is, if the main man stops generating impulses, somebody else will take over. If you don't love your wife, somebody will take her. So it's the same way. The atria, the SA node fails to generate, and the ventricles take over. So there's no P waves, and they have a widened QRS. Okay, let's look at rhythm number 9. What's the rate here?
Sir, does the AV node also fire?
Yes, sir, it does fire.
Okay.
Thank you. So rhythm number 9. What's the rate? So this is, you can't find a rate here because it's chaotic. What's the regularity? Is it regular, irregular? Irregular, I agree with you. What are there P waves that we can see?
Irregular.
What's the PR interval? None. What's the QRS duration? Wide or narrow? Wide. Fantastic.
Wide.
Then how do you interpret this? Chaotic basa V fibrillations, and also ventricular fibrillation. When you see this, is the next thing is the person goes if you don't do anything. So the reason to recognize is the fact that you definitely need to, and that's the essence of BLS, ACLS, that every hospital, every medical school, every market should have a ventricular, what do you call it, a defibrillator, so that when you see these things, then you can appropriately manage those guys. So we said the ventricular fibrillation completely, most of those guys have abnormal chaotic rhythm. And like I said, the ventricular cells can become excitable if the main man up there does not depolarize. And like, again, I mentioned, there can be a rapid drop in the cardiac output because everything is basal. There's nothing really contracting. And then you can have sudden cardiac death if you don't quickly do this. So this is the end of the second part. Again, if you think you've had enough to bite, feel free to exit before we move on. So we open the floor. If you have any question, if you have any contribution to make, kindly go ahead. In-house first before the Zoom people. Any question? Okay, Zoom people.
Please, can you go back with the rates, the calculation of the rate?
The rate, okay. I see that we really need to calculate the rate. So 3 ways, let's fire up there. See, just a minute. The rate, okay, I get that. So you see, we really need to grasp the first step, the rate, because that's the key to opening the door. If you don't start well, you can't do the rest of the things. So the rate, there are 2 options that have been put here, but actually we can even get 3 options. The best way to get the rate is to either use the 10 seconds rhythm strip or the 6 seconds rhythm strip. What do we mean by that? We said for every small box, the very tiny one, tiny, that's 0.04. So if we multiply 0.04 by 30, by all these boxes, from here to here, if you count with me, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. Oh, sorry. So up to 30. Now, we said the big box here is 0.2, or so, 0.04 times 5. So if you multiply all this, you realize that what you come up to is 6 seconds. And there are others that you can actually count up to the 10 seconds. So now, if it is 6 seconds, what do you do? What you do is simply, heartbeat is measured in beats per minute. How many seconds make a minute? 60 seconds. So if you multiply 10 by the 6 seconds, you get 1 minute or 60 seconds. So what we are simply, forget about the English. What we are simply saying is that if you want to determine the rate accurately, you can use the 6 seconds. So count 6 seconds, and that is count 30 boxes. So from here up to 30, once you get 30 boxes, mark here and mark over there. Count the number of R waves inside these 30 boxes. That's 1, 2, 3, 4, 5, 6, 7, 8, 9. Multiply 9 by 10, that's 90. So that's the rate. That's option number 1. Second option, if you have the 10 seconds one, count to the 10th second, and then count the number of RRDs and multiply that by 6. Option number 3, if you don't want to waste your time with all this long term, and you have been able to identify that the rate, the heartbeat is regular, that is between here and here, here and here, here and here, it's all the same. If we were to put what's the name of that instrument that we use, a clipper or caliper or something, a clipper to mark here and mark here, if you turn it to mark here, it will be the same. And so if you are able to determine that this is a regular rate, what you simply need to do is to count the number of big boxes inside, in between this and that, or in between this and that, or in between this and that. And you just count the number of big boxes. So assuming we use this one, the number of big boxes, this falls on the bigger line. So 1, 2, 3, divide 300 by 3, you are going to get about 100. 100 is not so different from 90. Reason is that if you look, there are some tiny ones here and tiny ones there. Last option, if you want to be more specific, you want to calculate the number of very tiny boxes, the very tiny ones, inside between this and that, and divide 1,500 by those tiny boxes. You'll get the heart rate. once you have a rate between 60 to 100, you are comfortable that this is a normal heart rate. More than 100, you say that's a tachycardia. If there's a P wave before every QRS, then we say it's a sinus tachycardia. If it is slower than the 60, then we say it's a bradycardia. So these are the several options that you can use. Choose the one that you are comfortable with and go ahead to use that. Are you okay, or you need any further explanation about the rate? The one who asked the question.
Excellent.
To the one who asked the question. Oh, she's lost. Hello? Okay, I guess she's gone. Okay, so we'll move on. Well, atrial fibrillation. Okay. So someone is asking about atrial fibrillation. Is that not so? What? Please, the atrial fibrillation. I got confused. Dr. Amina, if you can unmute yourself and let me know the specific part so that we can take it.
Hello, please, how to know it is atrial fibrillation? That's how I got confused.
Okay, fantastic. Great. So on to atrial fibrillation. Let's roll. So let's go here. All right. This is a normal ECG. We said that you want to see a P wave before a QRS. Every QRS should have a P wave, and it should be discernible. It should be seen, evident as the P wave, representing atrial contraction. And we said that between one R wave to the next should be the same. So if you put a clipper from here or a caliper from here to there, and you use a paper to trace a rule or stated to trace from here to there, this distance should between here and there should be the same as this distance, and that should be the same as this distance. Obviously, even the blind can see this. This is bigger than this one. Is that not so? So it is not regular. Now, if you are looking for P waves, like when we got to this place, I asked, somebody said he can see 2 P waves. Another person said he can see 4. Someone said he can see millions. You see, so it just means that we are all seeing different things, and that makes it even difficult to see. So they are not discernible. You can't really appreciate it. So if you want, is this the P wave? Is this the P wave, or is this the P wave? It's bizarre. It's difficult to say. Or if you go over there, is this the P wave that is inverted? Is this the P wave? Is this the P wave? Is this the... No, you can't tell. The reason is that the ventricle is fibrillating. They call it small F waves, fibrillary waves, small F waves. So it's like somebody who has tremors. That's how the atrium is behaving, you see. So really, you can't see descendable P waves. Anytime you don't see descendable P waves with irregular RR interval, you can always bet your head that it's an atrial fibrillation. The good thing is that clinically, you can also pick this up. If you palpate the person's pulse, it's basal. There's no regularity to the rate. So we call it an irregular heart rate. So like you can see from this, if you are going step by step, if you pick the rate, this rate will be difficult to say unless you use the entire 6-second strip or use the 10 seconds. And so that one, if you count, you realize that this is about 100 beats per minute. The next one was the regularity. Regularity, we said, if you watch from here to here, it's different from there and it's different from there. So it's irregular. You see that? The next one is the P waves. We cannot see P waves. The PR interval. Anytime you don't see a P wave, obviously you can't tell a PR interval. The QRS duration, we said that one is normal. And we said that normal QRS interval is between 0.04 to 0.12. Or if you want to be a simple man like me, between 1 small box to 3 small boxes. Once it is like that, it means that it's a narrow complex QRS or a normal QRS. So it's 0.06, that's normal. Now, putting all this together, you can confidently say that it's atrial fibrillation, and that's how we pick it up on the ECG. Do you understand, or you have any particular issues that we can address?
Please, I get it.
Fantastic. I'm happy you get it. All right, so we can move on now. think we're at slide number 45. Okay. So we are done with the third part. Now to the fourth, diagnosing and MI. How do we do that? The reason is that, of course, where there's a 12-lead ECG for you to be able to try your hands on, you should be able to confidently diagnose a myocardial infarction, especially when you see it on the ECG. So to diagnose a myocardial infarction, you need to go beyond just looking at the single rhythm strip that we have been talking about and obtain all the leads, obtain the 12-lead ECG. So unfortunately, some people do have like 3 leads and others do have 6 leads, but we need 12 leads. The reason is, of course, just like if you go to the Molly National Park and you stand in front of an elephant, you see a different view of it. And somebody at the side of the elephant will see a different view because it's a big object. The same way with the ECG, you need to look at it, the various leads, look at it from different angles. So let's start. That's the rhythm strip. Usually for the 12 lead ECG, the one down there typically we select lead 2 to be the rhythm strip. Sometimes some people do select other rhythm strips. You can always select that on the ECG machine. We have one here that we'll be looking at practically. So that's the 12 lead ECG, like I've already said. Of course, I've explained this already. So how are the 12 leads included, or how are they gotten? So you have 6 of them, usually what we call the precordial leads. And then you have 3 of them on the limb and then 3 augmented limb leads. So total will be 6. So you have 3 limb leads, lead 1, lead 2, lead 3. Like you can see up there, the various axes that it looks at. And then the 3 augmented leads, they are usually the AVR, AVL, and AVF. And then the last but not the least, obviously, is the 6 precordial leads that we have just talked about, from V1 to V6. So if you combine all of this, you can easily diagnose a myocardial infarction. Now, one way to diagnose an acute MI is to look for elevation of your ST segment. Mind you, there's what is called a J point. And some young people do have what we call J point elevation. We'll be looking at that. Let's keep things simple. If you find an ST segment elevation, you don't know what it's about, it's better either to call a senior person to look at the report. Pastor, Pascal, please. Oh, this man. Let me search him and mute him. So if you find elevation of the ST. All right, let me mute everyone again. I see Victor has his hand up. You can unmute yourself if you want to stop me before I go on. Okay, otherwise, so the ST segment. Now. Sorry? So typically, elevation of the ST segment is where we have. Oh, I muted this guy. Why did you unmute? Pascal, do you have a question? I muted you. Why did you unmute? Okay, let me mute. All right, so let's go on. Elevation of the ST segment, usually greater than 1 small box in 2 leads, is typically consistent with a myocardial infarction. Like we'll see, the various leads look at different aspects of the heart. And so you don't just find a single lead and then maybe an elevation in either only V2 or an elevation in AVF, and then you go ahead to say that that's an ST elevation myocardial infarction. It's good that they are in two, what we call two contiguous leads, because the leads do look at different aspects of the heart. So like you can see that circle there, that's obviously an ST segment elevation. Another one there. And these are leads that are contiguous, looking at the anterior aspect of the heart. And so when it is that way, we say that this is consistent with an ST elevation myocardial infarction. So what leads look at the anterior view of the heart? So from V1 up to V4. Typically V5 and V6, we push them to the lateral aspects because they are more lateral. So that's there. So an anterior, in fact, like we said, if you find any of those changes consistent with that in V1 to V4, then you are confident to say that this is a myocardial infarction of the anterior part of the heart, i.e. an anterior myocardial infarction. So let's put all of this together. Very simple. Those on the Zoom, who do you think this person is having a myocardial infarction? Anyone who wants to answer should go ahead. Pascal. The guy likes to unmute himself. Pascal, answer the question since you are unmuting yourself.
My system is not working well here for me. I can't hear well. And
yeah, we can hear you now. So go ahead. What do you think? What do you think?
hear you.
You having an MI?
I'm saying that I don't know what is the phone or the network. It got a point it was breaking where I wasn't getting.
Okay, so anyone who has an idea of this?
Yeah, this is an MI.
Yeah.
From lead V1
yes,
to V3.
V1 to V3.
Yeah.
Yeah, so just like we talked about, V1 to V3, which part of the heart do you think this looks at?
The anterior part.
Fantastic. So we just talked about anterior MI. So we said that right from V1 to V4, they look at the anterior aspect of the heart. Some people do say that V1 and V2 are considered as septal leads. But the truth of the matter is that whether it is anterior going towards the septum or anterior going towards the lateral aspect, they look anteriorly. So I agree with you. This is an acute anterior wall myocardial infarction. So we move ahead. Fantastic. Okay, I think we have answered this. And like we can see over the V1, V2 is elevated. Is that also? So let's look at the ones that look at the lateral side of the heart. So we said that we have limb leads, we have augmented leads, and we have precordial leads. So let's look at each of these, made up of 3, 3, and 6. So in terms of the limb leads, anybody who has an idea of which of the limb leads look at the lateral aspect of the heart, you can please answer on the Zoom.
Okay, I think V5, V6, and
no,
leads
I'm
one.
saying that the limb leads. Let's take it step by step. Which of the limb leads look at the lateral side of the heart?
I think
V1.
No,
not V.
AVL.
No, I'm talking about
lead one.
Fantastic, lead one. So I can see, you can see, look at something. I asked limb leads. You see, these are what we call limb leads. Lead 1, lead 2, lead 3. Or Roman number 1, Roman number 2, Roman number 3. The next one is what we call augmented limb leads. Those are the AVL, AVF, and AVR. And then you have the precordial leads. So the first question was that, in terms of the limb leads, which of them look at the lateral aspect of that? It is this man, lead 1. The reason is that, like I see that arrow there, lead 1, over here. Now, the next one is, in terms of the augmented leads, which of them look at the lateral aspect of the heart?
AVL.
AVL, fantastic. So AVL. How about the precordial leads from V1 to V6? Which of them look at the lateral aspect of the heart?
V5, V6.
Fantastic. So we are done. So if you see ST segment changes in lead 1, AVL, and V5 and V6, what are we talking about? Is it not a lateral MI? Great. So let's move. So that's it. So lead 1, AVL, V5, and V6. All right. Next group is the inferior leads. So the limb leads. Okay, to in-house. The limb leads. Priscilla. Where's Priscilla?
Lead 1 and 3.
No, lead 2 and 3.
Okay,
okay. 2 and 3, number 1 and 3.
Lead 2
limb
and
leads.
3.
You answer all about inferior MI. The limb leads, which of them look inferior?
Lead 2 and 3.
Fantastic. Lead 2 and 3. Okay, how about the augmented leads? ABS. How about the precordial leads?
No.
Any answer? Okay,
None of
so
it.
none of them. None of them. All right. So move on.
None of them.
Okay. So ways the ECG can change will include, like I have the ST segment elevation. You can have the ST segment depression. So like I can see from those arrows, an elevated ST segment, a depressed ST segment. Is that also? Now we look at the T waves as well. Dr. Bismarck's favorite part, the T wave. Is that also? The T wave, you can have picking of the T wave, you can have inverted T waves. You can even have flattening of the Is that also? Then the other aspect that we have to look at is the appearance of the Q waves, what we call pathological Q waves. Typically, if the Q waves are more than a small box depression, especially in contiguous leads, then you are likely dealing with pathological Q waves. Typically, most people use the inferior leads to look at that. Now, changes and then evolving MI. The thing is that we have to be careful because a normal ECG does not rule out a myocardial infarction, especially a STEMI, ST elevation myocardial infarction. How it starts is that it starts as a normal ECG. So there we usually say that we do what is called serial ECGs. Let me see if I can move this people. All right, great. So let's move on. So you can have an ST elevation myocardial infarction or a non-ST elevation myocardial infarction. All right. So the changes with ST elevation myocardial infarction, like I said, before the injury, you have what? A normal ECG, is that also? Now the ischemia, when it sets in, you can have the ST segment changes, ST depression, picking of the T waves, and then you can have inversion. And when the real infarct sets in, is when you then have ST elevation and the appearance of Q waves. We pray that we don't have to wait until the ST elevation sets in. But unfortunately, most of the times people come in and this is what happens. All right. Then, of course, if we don't do anything about it, that side can get fibrosed, healing by secondary intention, or you can even have sort of, what do you call it? A rupture of the side that is involved. So ST segment and T waves can return to normal, but then the Q waves will persist, indicating an old infarct. So the bigger thing now is to look at ventricular hypertrophy. That's another area that a lot of people have put names to. Rule of thumb, you see, the thing about it is, yeah, someone is asking a question.
There's an interesting question in the chat, so if we take a look at it.
Yeah, just read it out so that we'll hear.
Okay. My question is, does the ST segment abnormalities in relation to myocardial infarction also capture infarct of the atrium or the ventricles only, since that section of the ECG is recording information from ventricular electrical activity?
Yeah, so it's ventricular.
Okay.
All right, thank you. So
how on ECG, how will you able to capture an atrial infarct?
I don't know.
Okay.
All right. So there are criteria to diagnose LVH using the 12-lead ECG. So typically, a lot of people have names on it. But like I was saying, there are easier ways of picking up most of these things. You can either decide to look at the precordial leads V1 to V6, or you look at the limb leads, or best if you combine the limb leads with the precordial leads. So don't mind about the plenty names. Common things are common. If you decide to pick the precordial leads, the commonest one and the most accurate by all far is the Sokolov, which uses the R wave in V5 or V6 plus the S wave in V1 or V2, more than 35 millimeters. So if you combine that with a limb lead one, like the augmented limb lead, commonly we use the AVL criteria. That's the best one. If you combine that with AVL more than 30 millimeters, and you satisfy these two criteria, you are damn sure that it's a left ventricular hypertrophy. Some people do combine V3 with AVL, and then they say that in men, if you have it more than 23, or in women more than 20, then of course you also satisfy the criteria. Others say 28 anyway. So of course, rule of thumb is just to pick what you are comfortable with and usually do. But essentially, if you involve the precordial and the limb leads, and the more criteria this satisfies, the more that your diagnosis of an LVH is likely. And even people do add the other aspect of a left axis deviation, because once there's LVH, the axis goes leftward. Okay, let's move on. So the first thing, we can look at the axis as well, just like I've talked about. So typically, again, to make things simple, I like to use lead 1 and AVF. Some people combine lead 1, lead 2, and AVF. Like you can see in this one, lead 1 with lead 2 being predominantly positive means a normal axis. Again, I would have added AVF to this. If AVF is normal, it's positive, means normal. If you have a predominantly positive deflection in lead 1 and a negative deflection when you resolve the vectors in lead 2 or AVF, that's left axis deviation. The reverse for a right axis deviation, as you can see over there. So where you have a negative lead, predominantly negative this in lead 1, and then positive in lead 2, and as well AVF. So question to Zoom participants, is this QRS axis normal in this ECG? If you combine what we have just said, anyone can answer. Just unmute yourself and answer, then we'll move on. Okay, in-house people, normal, abnormal, left or right axis?
Left axis.
Left.
Okay, left axis deviation. So we'll move on. Great. Now the rate, the intervals typically will refer to the length of like the PR or the QT intervals, and then the width of the QRS complexes. So anytime you hear about and a PR interval, QT interval, and all of that, you need to know that it combines a wave plus a segment. That's as simple as it is. So we'll be looking at what is normal and what is abnormal, and then the common problems that we see. So we are going to look at, okay, the right atrial enlargement, left atrial enlargement, right ventricular hypertrophy, and then left ventricular hypertrophy. I think we're already done with the left ventricular hypertrophy, is that also? So let's pick the right atrial enlargement. Let's look at this ECG. Anybody from the Zoom participants, take a look at the P waves, a critical look at them. What can anybody make a long statement about the P waves? You can just unmute yourself and then fire. You see, this is a P wave here, this is a P wave there. You see a P wave there as well, P wave there, P wave there. Anybody wants to take a try, it's always good to try, is that also? What do you notice about the P waves? Nobody?
Some is longer than the other.
Fantastic. So some is longer. I like that. Some is longer than the other. So now let's dwell on those who are which are longer. Dr. Amina, which ones are longer?
I can see the one in lead 2.
Yes, that's true. I agree with you. Any other one, or that's all? You don't agree with me that in lead 3 as well, you seem to have more than one box.
Yeah.
Okay, but I agree with you. Obviously, the very obvious one is lead 2. Is that also? Is the amplitude is longer. Now, how about anybody take a guess or a look at V1 and what the P wave here looks like? Anyone at all? Okay, in-house, V1. Maybe, I don't know, maybe whether I'm straining my...
I think they are bifid.
Fantastic. So they are bifid. They are bifid P waves. Is that also? Now, if we say, you say they are bifid, look at the bifid means 2 angles. Is that also? There is one side and the other side. Look at the various sides. The one who said is bifid. Which side is bigger? Is it the one going up or the one going down? This is what it means by bifid. If you trace this, you see that up, down, goes down, comes back. So which one is of a bigger depression or elevation? Is it the one going up or the one coming down? Fantastic. So it is the one going up. Is that also? You can't. Let's take it again. The first thing, like Dr. Amina mentioned, which was fantastic, is that if you compare the P wave in lead 1 to the P wave in lead 2 to the P wave in lead 3 to this, to this, to that, there's one that stands out clear. The one in lead 2 is prominent, is peak, is big, is tall, is of a bigger amplitude. Is that also? You get that one, is that not? Now, if you look critically at all of them, there's one that looks like, what do you call it? Is it dumbbell? Or this what they call it? So it's bifid. I don't know another word for it. Like it's bifid, that way. This particular one, I don't know whether the cursor does it. Okay, it comes. So take a critical look. There's something going up, it comes down, and it goes a bigger depression, then comes back. Even here as well, you see up, down, and back. So it's like that. So there's an initial part and a terminal part. The good thing about the V1, like you can see with the P wave, is the fact that the right atrium gets a little earlier depolarized than the left one. Is that also? Because of the fact that the SA node is in the right atrium. So you have the first depolarization happening in the right atrium and the second part of it being in the left atrium. And so that bell is able to separate them and tells you that is it a right atrial problem or a left atrial problem? You get the point. Now, I was asking the question about if you compare the upward elevation to the downward depression, you realize that what goes up is bigger than what is coming down. Down is actually very minute, is that not? And we said that the first part of the P wave represents right atrial contraction. And so the bigger the right atrium, the more the amplitude will come in. The bigger the left atrium, the more the depression and the duration will go. The other thing about it is also the fact that the right atrium, even no matter how big it's going, it cannot expand. The duration cannot expand. So you check right atrial issues, what they call right atrial abnormalities, by the amplitude of the wave. You check left atrial abnormalities, mostly by the duration, because that allows time to become broad. You see, so we'll look at that simply, but it's because you are so that we just make it. Oh God, I will skip. So if you critically look at if you critically look at the P wave for the right atrium in this particular one, the first part of the dumbbell, what is it? The first part of the dumbbell, or the first part of the, what is it? Exactly. So something like that. So the first part, the upward elevation is bigger than the downward depression. And so it represents the right atrial enlargement. And so that gives it away. So this is the right atrial enlargement. So like we said, the P waves are tall. Thank you, Dr. Amina, for that great lesson. Especially in lead 2, she saw it very prominent in lead 2, but I was adding that you can see it in lead 3 as well, and even in AVF. Typically, like they will say if you sit on those P waves, they'll definitely hurt you. They are spin pointed as possible, like you can see over there. So that's it. That's all about right atrial enlargement. Very easy to pick up. So just combine those two. So how do we diagnose that? You look at the D2. If the P waves are more than 2.5 millimeters, or the V1 or V2 more than 1.5, typically you can go in for a right atrial enlargement. It's best done easy by combining the inferior leads with V1. V1 typically will show you that, you keep forgetting about that, the biphasic wave. All right. So this just shows what we have essentially gone through. The cause of right atrial enlargement is right ventricular hypertrophy, usually from pulmonary hypertension. So let's take note of that. Now that we are done with the right side, let's look at the left side. Now that I've explained it to you, Augustina, you have to tell me how we diagnose left atrial enlargement from combining lead 2 and V1. So the P wave in lead 2. Exactly. Yeah. How about in P1? The P wave there. Do you notice any difference in the one going up and any difference in this one down there?
Yeah, I'm going down instead.
Fantastic. So the one going up, we said, will represent the atrial enlargement. You guys, when you unmute yourself, you make it. I will decide to mute everybody on the Zoom so that you can contribute again. Because how do you unmute yourself and then you make background noises? Okay, so let's go on. So the one going down, you realize that is a bit broader or longer of a longer duration, and that represents the left atrium, and it is bigger and broader than the right one. All right, so let's move on. So the P waves in lead 2 are notched, and in lead V1 they are deep and wide, and of course that goes for left atrial enlargement. The thing is simple if you take it bit by bit. If you want to combine everything, then it becomes a problem. Okay, so again, if you look at lead 2, obviously, if you have more than one box between the notch picked or the negative deflection is more than a box deep and a box wide, then you go ahead to diagnose the left atrial enlargement. Okay, now that we are done with left atrial enlargement, right atrial enlargement, let's go down to the ventricles, the ventricular hypertrophies. The first one is the right ventricular hypertrophy. Okay, so those on the Zoom, someone should answer this one. If you look at this ECG, what do you notice about the axis and the QRS complexes over the right ventricle? That's the ones looking directly over the right ventricle. That's V1 and V2. So anybody can answer the first part of the question. What is the axis? I think we have already dealt with axis. So fast. What's the axis of this ECG? Anybody can unmute and answer. If you put it in the chat box, I will not be able to read. So just unmute yourself and answer.
Okay, we have a right axis deviation.
Fantastic, great. So I agree with you. It's the right axis deviation. Okay, so now the next thing is that let's look at the leads that are looking directly over the right ventricle. What do you notice about the QRS complexes in V1 and V2? Oh, anybody, just unmute yourself and go ahead. Please unmute yourself and go ahead. Okay, in-house, anyone? Yaula, ECG man.
So the P1, ideally, you should have an R-width and progression from P1 to P6, but it seems like the P1 are longer than the P5 to P6. It seems like the R-width to P1 abnormal, so it's longer than abnormal.
Fantastic. I agree with you. So that is it. Progressively, usually we say that the R wave should start from a smaller amplitude and progressively get bigger as we get to the apex. That is the left ventricle, because the left ventricle has a bigger mass. And so this R wave will obviously be bigger. But if you look critically at V1, like Dr. Jaula said, if you look at V1, you realize that the R wave is greater than the S wave. It's big. The R wave, again, for lay people like me, is the first upward deflection or first upward elevation. So this is what we're talking about. If you compare this R wave to the one coming down, which is the S wave, this is, of course, bigger than this small thing. The same way, if you come to V2, the R wave is bigger than this. The reverse is if you get to V5 and V6. So it's this V5. The R wave, although it's a little bigger, but S wave is now there. So if you realize the R wave progression, of course, is a poor R wave progression. And the R wave in V1 is bigger than the S wave, which is not normally what should happen, because the bigger mass is in the left ventricle. And so if you combine these two, i.e. the right axis deviation plus the R over S, or R wave being greater than the S wave in V1, or if you compare usually the S and R wave again in V5 or V6, and then the S wave is bigger than the R wave in V5 or V6, then you are confident enough to say that this is a right ventricular hypertrophy. Those are just the two, and you are done. Right ventricular hypertrophy sorted out. Okay, we'll go to left ventricular hypertrophy. Again, let's take a look critically at the ECG. Zoom people, what is the axis of this ECG? Anyone, you can just unmute and answer.
Left axis deviation.
I agree with you. Left axis deviation. Can you explain why it's left axis deviation, or how it is? What leads you combine to say that it's left axis? Oh, the one who answered the question.
There's a positive deflection of the lead, the first one, and then
Okay,
negative
so lead
deflections
one.
of lead one. I can't really see them. Then negative deflection on the second
So
and
this
the
is
third
lead one. It's positive.
Yes.
Okay, and you said there's a negative deflection. Which of the leads?
If you come down small, I think is it lead. I can't really see this one.
Yeah, so this is lead two.
Pointing, yeah, where you're pointing.
Lead two.
And
so I agree with you that there's a more negative deflection in lead two. Is that not so?
Yeah.
And even if you go ahead to
that one,
yeah, this one too, there's a predominant negative deflection. Is that not it? All right, so we are confident enough to say that this is a left axis deviation. Fantastic. Now let's look at the leads that look at the left ventricle. That is, if you go to V5 and V6, anything that you have noticed. If you look at V5, this is V5, this is V6. Anybody who has noticed any particular thing about it? Zoom people. If you compare the R wave, it's prominent here, is that also compared to this one? We compare this R wave as well. So it's prominent, is that not it? Then we'll go to the leads that are looking over the right ventricle. That's V1 and V2. You realize that the S waves are deep. You find a very deep one there, another deep one. With eye of faith, you realize that if you add this to this one, obviously it will be more than the 35, satisfying the Sokolov criteria, is that not it? Again, if you go ahead to look at AVL, I don't know how many boxes this would be. usually more than 11 or more than 13, like in some books. Again, that can satisfy the criteria. If you decide to go with the most accurate one, that you can use V3 plus, what is V3, V1, V2, V3. So if you look at the S waves here in V3, and then you combine that with the R waves in AVL, more than 20 for women, more than 28 for men, then we were able to satisfy that criteria. Okay, so again, there's a left axis deviation, like one of the participants on the Zoom said, because it's positive in lead 1, negative in lead 2. Even if you look at AVF as well, it's negative. And there are tall R waves in V5 and V6, like I said, and deep S waves in V1 and V2. So this satisfies the criteria for left ventricular hypertrophy. So we are good. We'll be able to look at atrium, atrial enlargement, left, right. We've gone to ventricles, right ventricular hypertrophy. We've looked at left ventricular hypertrophy. So the next thing that we have to, okay, still now on the criteria. Obviously, we can skip this since we have already talked about it. So this guy is somebody has put his name here. The R in V5 or V6 plus the S in V1 or V2 more than 35. The one who did this put his name there, Sokolov. So they call it the Sokolov criteria. AVL more than 13 is also there. There are so many other criteria. There's even a Nigerian whose name is there. I think it's Arauye. He has modified it a bit and also put his name there. Never mind about the several names. For practicality purposes, just know one or two of them, one for the limb list, one in the precordial list, one of the criteria for each. And if you satisfy that, you are good enough to go, except for those writing exams where they ask the various criteria. So in summary, what we have been able to do throughout this presentation is that we'll be able to calculate the rate. We'll be able to determine the rhythm. We'll be able to determine the QRS axis. We're able to determine intervals. We went ahead to look at hypertrophy and enlargement if you are talking about the atria. We've looked at evidence for infarction and the various angles that it looks at. So we are good to go. Now that we are happy about this, I'll throw a question at random to the floor. Dr. Jaula, a 16-year-old young man ran into, I don't even know what a guardrail is, while riding a motorcycle in the emergency. He's comatose and dyspnea. And he went, and this is the ECG Dr. Blankson has shown to you. What's your comment? Okay, fantastic.
When you look at the rate, it counts, I don't know which rate the other the 6 second or the 10 second, which just by consider it's
okay. So if you want to estimate the rate, what will you say? Like just using, it looks regular, is that not so? So if we just divide 300 by, so about 150, 130, 150, so fair. All right, so it's tachycardia. Let's move on. We've done the rate. Okay. 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 Yeah. Great.
This is a trauma. You can't see an MRI, but can rather go for the condition.
Fantastic. Mm-hmm. All right. So I agree with you. That was it. Nothing much to add. So the take home is that beware that it's not only those who have hypertension or diabetes or any of those diseases that are the only candidates for ischemia or infarction. Coronary artery injury can in rare occasions after a blunt chest trauma, you can have what do you call it? A coronary artery injury. And like you can see in this particular guy, like Dr. Jaula said, if you look critically, you realize that there's a 2 millimeter ST segment elevation, right from V1 actually. It's not so descendable there, but if you go to V2, it's there. So from V2 to V6. Typically in these people, unfortunately, most of us don't request for cardiac enzymes. But if you see this, you have to request for cardiac enzymes. And it's unfortunate again that you request for this and it takes 2 weeks to come because the sample has to be sent to South Africa. By the time it comes, it's of no importance. But where things are done right, if you request for it, typically, and the enzymes come and they are elevated, especially now the newer one, the highly selective cardiac troponins. Once it's elevated, it pushes you towards that. But this particular man, because he's comatose, of course, he's not going to complain to you about chest pain. Another group of people you should be careful about is those who are diabetic. They have what is called silent MI. So they may come and routinely, you don't screen them. Routinely, all of them need to have an ECG, whether they complain about chest pain or not, so that then you can intervene when it's necessary. So typically for this man, if you did an echo, you realize that there will be akinesia, typically in the anterior septal, because it's involving V2, which is a septal lead, even a bit of V1, V2 up to V6. So obviously, you may find that you may have akinesia. So these are the people that we should be careful about. Where things are available, but this person cannot be a candidate for thrombolytic therapy. The reason is because of the trauma and possible brain injury and all of that. Otherwise, if it wasn't because of the trauma and it presents earlier and in a PCR capable facility, obviously they can go ahead to do that with the coronary angiogram and follow it up with stenting. So these are things that we should know about the ECG. You see, if not for this, obviously everybody would have just been thinking that the coma and all being dyspneic is all because of the fact that maybe there's an internal bleeding or inner bruise. So we should be careful as well. Okay, so let's see if we can. The rate, I think Dr. Jaola mentioned that is about between 130 to 150. And then the rhythm, we said, is sinus tachycardia. The QRS complex, if we technically look at it, like we said, in lead 1, there's a predominantly negative deflection. So it's a right axis deviation. Then we can look at the PR and QRS intervals. Typically, the PR, if it is about 0.12, I'm sure if you had calculated with me, and then QRS interval is about 2 small boxes. And then the QT interval is about 0.48. Now, the other thing is about the enlargement. Whether here we find any evidence of enlargement. We don't see that. Ventricular hypertrophy, if you are using any of the criteria for both the right and left, you don't find any of that. Key waves, if you look at V1 to V6, there are key waves there. And then as well in the lateral leads. So those are shown. And then ST elevation or ST depression. So we find that from V1, V2 to V6, lead 1 AVL, and then you have a depression in lead 1, lead 2, lead 3, lead AVF. They are what is called reciprocal changes. So we are getting to the end of it. Are there any T wave changes here? Anyone who can see any T waves and T wave changes? Dr. Michael, T waves. Do you see any T wave abnormalities, or do you even see T waves at all? All right. So there are no T waves. I agree with you. So in the ECG that you see below, there's sinus tachycardia, like Dr. Jaola said. You have right axis deviation, long QT, and evidence of ST elevation in the anterolateral leads, with the reciprocal changes, like I said, in the inferior leads. Okay. And we said that this man, the young man, suffered an acute MI after the blunt trauma. And an echo showed anteroseptal akinesia, like we're just talking about. Angiogram showed occlusion of the LAD, the proximal LAD, with the collaterals from the right circumflex and the left circumflex and right coronary artery. All right, so we are good. Just the icing on the cake, last part, the blocks. I'll go faster. So we have first degree block, second degree, and third degree. Yes, a question before we go. Okay.
Doc, sorry, can you help
Sorry,
us
there's
with
someone in-house, so please hold on.
And
Yeah,
we can't
let's go.
hear them.
I will repeat it when she does.
Thank
Are you logged onto the Zoom? No. Okay. If you are, just unmute yourself so that the Zoom people can hear you. All right, then go on. Mm-hmm. Mm-hmm. And AVR or AVL. Yeah, so AVR is the true right-sided lead. It's always negative. If you find a positive, you have to run for your life. Okay, so is that the only lead supposed to be negative? Yes. Sometimes I saw about ECG the way is also negative. Yeah, so the only right-sided lead is AVR. Typically sometimes depend on the way the leads are placed. You can actually, if you don't place them well, it can give you palpitations. So that's the reason why you don't jump into analyzing just an ECG without looking at how training people on how to place them very well. So in terms of negativity, really is mainly AVR. That's the true right-sided lead. And like we say, anytime a positive current is moving away from a positive distance, it gives a negative deflection. And if it's coming towards, it gives a positive thing. The right side, because most of the electrical axis swings towards the left, because the left ventricle is bigger. So it's going away from that side, so it's negative. You get the point. But of course, like I say, you don't pick one thing in isolation. Even if I find a negative lead 3, is it of significance? You have to always ask yourself, that is it, what you are seeing in lead 3, if you are talking about an MI, it needs to be contiguous. And which are those leads that, in addition to lead 3, look at the septal part. Those are lead 2, lead 3, AVS. So I find a single lead there, I will not have palpitations. You get the point? You good? Yeah. All right. Okay, so she was just asking about a single lead that has issues, negative deflection, what to do. So that's what I explained. Okay, so move to the nodal blocks, the last part of it. So we have the first degree, second degree, and third degree, or complete block. That's third degree. So second degree, we have Morbis type 1, Morbis type 2. We'll be quick about this one so that we can finish up. I've been talking for more than 2 hours. So first degree block, we realize that we said our PR interval should be between 3 to 5 small boxes, or it should be 0.122 to 0.20 seconds, not more than that. Anytime you have it more than that is a first degree block. So if you agree with me, if you trace from this man, this P wave there to this QRS, is more than a big box. A big box is 0.2. This is 1.5 or more boxes. So obviously it's prolonged. Okay. And typically, let's go. The rate, if we look at this one, the rate is about 50 beats per minute. Of course, 50 is less than 60, so it's a bradycardia, is that also? But if you look at this P wave, it's normal, but this keeps prolonging, becomes even longer, and you don't see anything here. Then the man starts again, normal, prolongs, you don't see anything again. They have this husband and wife thing. I never like to use it. So just take it that the thing gets prolonged and drops off. There's nothing about the man not being faithful or any of those things. The P wave, if you look at over there, this one, you see a P wave, but you do not see any QRS. So progressive prolongation of the P wave till it drops. And the interval keeps lengthening, like we mentioned. The QRS is normal. What's the interpretation? We think that it is a second degree Morbis type 1 AV block. What happens in the type 2? This is still type 1, deviation from the normal. The PR, we've already said it. So let's go to type 2. The rate here, if you calculate with me, is about 40. So it's a bradycardia. But if you notice, there's a P wave here before the QRS. But it comes here, you don't see any P wave. You don't see any P wave. The thing comes again. And then normal, then P wave, no P wave, then a P wave comes. So this is, the regularity is regular. The P waves, you tend to see that there's the presence of P waves, but if 2 or 3 of them, if you look at the second one, you don't find any P wave and any QRS following that P wave. So the PR interval is also a progressive prolongation. And then the duration of the QRS is normal. So where some P waves come in without QRS and following a particular pattern, like a 2:1 block, a 3:1 block, that kind of thing, typically we say it's a second degree heart block. Then okay, so this is still second degree. The third one is where everybody is misbehaving. P wave comes, no QRS. Sometimes comes, the QRS is even lengthened, comes and there's none. So that one, the heart rate even goes lower and it becomes, the P waves have no relation with the QRS interval. And you don't tend to even find any PR interval because there's no relation. And so the QRS becomes widened because the ventricles try to take over to beat. That's a complete heart block, otherwise called the third degree heart block. So typically with the complete heart block, there's complete blockage of the conduction from the AV node. Remember that when an impulse originates in the ventricle or originates from the ventricle to the ventricles, the QRS complex will be bigger, like we have already talked about. I think all in all, we have been able to achieve our objectives by the fact that I'm sure all of us can now recognize a normal sinus rhythm. And you'll be able to recognize the rhythm disturbances. You're able to recognize an acute MI, and then you should be able to recognize the AV block that we have just talked about. So you're able to see one, you do one, you teach one. Thank you very much. Any questions? Zoom people, we'll start with you. If you have a question, please ask before we come in house and we'll close. 5 minutes.
Yes, Doc, I have a question.
Please do.
Yeah, with the Q wave, the notch, whereby you said there's a previous
It's very difficult to hear you. Your line is breaking.
ECG, and you realize that you have. Yes, I was asking with a Q wave notch, if you find one, does it signify there's a previous myocardial infarction, or when you find more than one on the ECG?
Yeah, so there's actually supposed to be Q waves every time. I guess what you are talking about is pathological Q waves or abnormal Q waves. Typically, if you find them in the inferior leaves, it's of much significance.
All right.
Okay. Any other question? Okay, so we thank you so much for joining us today. We've gone way past. Emmanuel, go ahead with your question. Okay, Emmanuel is off. So thank you very much for joining us today. We've overshot our time, but I think it's been worth it, and we are glad that you did join us. Hopefully, so for next week we are getting one of the professors, the president of the World Gastroenterology Organization, a gastroenterologist professor, who will be leading us with a presentation on climate change and health. So if you do make a date with us, I think it will be of benefit to everyone. I'm sure you can serve as mentor as well to all those that would wish to join in. All the best and have a great stay and take care of yourselves. Bye-bye.
Bye. See what somebody.